Good afternoon, everybody. Today, on behalf of the Department of Pediatrics, Unit 3, we'll be presenting a case which was diagnosed as infantile medulloblastoma. The challenges that the team faced while managing this case and how the associations of various cancers are known with this or unraveled while the child was being worked up, and how this patient was part of a rare syndrome would be presented in our in today's presentation. So with this background, I invite our residents, Dr. Arjun, our junior resident, to present the case, and our senior resident from pediatric oncology, Dr. Kritika, would be discussing the case. So there's a lot in the story which would be unfolded by Arjun and Kritika.
Thank you, ma'am. So good afternoon, everyone present. So beginning with the case discussion today. So the index case is that of a 7-month-old baby boy who presented to our OPD in the July of 2021 with chief complaints of being born with a large size head at birth and progressively increasing head size noticed by the parents since 3 months of age. Now, as we can see outside, the treating pediatrician has diligently maintained the head circumference growth chart. And since the beginning, the child's OFC was above the 2 standard deviation, hence classifying him as a case of macrocephaly. And over the course, the head circumference kept on progressively increasing. Antenatally, the child was born to a non-consanguineously married couple without any significant family history. First and second trimester were uneventful. The mother was found to have hypothyroidism, for which she was on appropriate treatment, and it was well controlled. The third trimester ultrasound scan done near term showed mild lateral ventriculomegaly, but without any mass or any lesion in the posterior fossa. So after birth, the child was born at term. LSC is done in view of non-progress of labor, and at birth, the cried immediately, and there was a smooth perinatal transition with a normal birth weight baby of 3.7 kilograms. Clinically, as I mentioned earlier, the child appeared to have a large head size, but without any sutural diastasis or bulging anterior fontanelle. So from 3 months onwards, the parents started noticing that the child had progressively increasing head size, although it wasn't associated with any history of vomiting, seizures, altered sensorium, paucity of limb movements, or any other abnormal twisting twisting movements or stiffness of limb, nor with any history of irritability or excessive crying. Outside, on general examination, a note of macrocephaly with dilated veins over the scalp was made. The AF was wide open but not bulging, and there was prominent bilateral sun-setting sign evident. But the child did not have any features of dysmorphism, any other anomalies, or any neurocutaneous markers. Systemic examination per se for the CNS showed that the child had intact higher mental function without any cranial nerve deficit and had normal tone and showed spontaneous movement of all the 4 limbs without any brisk DPRs. The rest of the systemic examination was normal. Antenatally, as I mentioned earlier, the child was detected to have ventriculomegaly. So hence, with this history of progressively increasing head size, outside he was evaluated with an initial MRI done at about 1 month of age. And as we can see, there was nothing grossly abnormal reported in this MRI. The child was also noted to have developmental delay when he presented to us at 7 months. As we can see, across all domains, the gross motor, fine motor, language, and social, the child had delay and was developmentally around about 3 to 4 months of age. Initial possibilities of genetic versus a neurometabolic cause were considered. And for the same, the workup, which included a urinary GCMS, was done, which was normal, and a repeat MRI was advised around about 7 months of age. So as we can see, the child's presentation at about 7 months, he has an apparent macrocephaly with bilateral sun-setting sign and a delay in the gross motor milestone, evident by the fact that he needs support even for sitting at 7 months of age. Now, at this juncture, I will pause and would like to discuss the differential diagnosis of macrocephaly. So, a large-sized head could be either due to the increased ventricular spaces causing due to the etiology of hydrocephalus, per se increase in the brain parenchyma causing megalencephaly, or skull wall thickening, which happens in cases such as hemolytic anemia, rickets, osteopetrosis, where their diploid spaces enlarge to accommodate and carry forward the extramedullary hematopoiesis. Now, presentation-wise, we could rule out the causes of skull wall thickening because the history and examination was not suggestive. Megalencephaly, though, was a probable cause, but was unlikely in our scenario. And hence, the front-running diagnosis of hydrocephalus, probably secondary to either congenital anomalies such as aqueductal stenosis, Chiari and or Brandy-Walker malformation, AV malformation, or any intracranial space-occupying lesions were kept up front. Now I would like to invite Dr. Stuti, SR from radiodiagnosis, to discuss the MRI which happened at presentation about 6 to 7 months.
Good afternoon, everyone. I shall be discussing the contrast enhanced MR for this patient. We begin our journey with the non-contrast image. That this is a T1 weighted image. We recognize it so because the fluid within the ventricles appears to be dark and the scalp fat appears to be bright. So we spot the obvious abnormality within the posterior fossa. We see an irregular mass which is occupying, expanding as well as distorting the fourth ventricle with further extension into the bilateral cerebellar hemispheres on the medial aspect. This is most predominantly seen on the right side. This appears to be an iso-intense mass on T1 and displays hypo-intensity on T2 weighted images. It is obstructing the fourth ventricle with upstream intraventricular obstructive hydrocephalus as evidenced by dilatation of the temporal horns. The next step is to do a contrast study, and for this, in this sagittal axial T1 and axial T1 weighted contrast image, the lesion shows intense enhancement and is seen to occupy the roof of the fourth ventricle. So as to summarize this case, infant with a posterior fossa sol, particularly arising from the roof of the fourth ventricle with intense enhancement and upstream hydrocephalus, our first differential would remain a medulloblastoma. Another possibility to consider is an ependymoma. However, ependymomas are much more heterogeneous. They arise from the floor of the fourth ventricle and are plastic tumors, so they tend to invade through the foramen of Luschka as well as Magendie. So medulloblastoma remains our prime differential in this case. I would like to invite Dr. Ninath for further discussion.
Good afternoon. Myself, Dr. Ninath from fellow in pediatric neurosurgery. So we posted the case for tumor excision, and these pictures are not for the particular this patient, but for showing the how we proceed. So we take a patient in prone position. Generally, less than 3-year-old children we take on the horseshoe. Otherwise, we prefer head clamp. So after that, midline suboccipital incision is given to expose the suboccipital bone, and this midline suboccipital craniotomy done. Then to expose the dura. We after give the Y-shaped incision over the dura to see these anatomical structures, like these are bilaterally both cerebellar hemisphere. In the midline there will be the vermis, and these are two tonsils. And in this picture we can see the tumor is coming out through the foramen of Magendie, and these are two tonsils. So generally this tumor was involving the vermis also, and as well as it was inside the fourth ventricle. So we took a combined approach, that transvermian and tilovelar approach, that is from the below after retracting the tonsils and through the vermis, because tumor was involving vermis. So intraoperatively, tumor was a pinkish white mass in the almost whole of the fourth ventricle. It was occupying, mildly vascular, well maintained plane with the floor of the fourth ventricle. So that is the good aspect of it, because if planes are good with the fourth ventricle, so brainstem involvement be not there. Imagine into the middle and inferior vermis, and CSF flow from the aqueduct was confirmed. So it is also a good sign that post-operatively patient might not need the shunt or any CSF diversion. So blood loss was very minimal, 100 ml. Then post-operatively patient was fine, no neurological deficits. Post-op day 3, patient was again posted for Umaya incision on the right frontal cocker spine, And our first attempt, we accessed the ventricle. CSF was straw color, and as expected, moderate pressure was there. And after both the procedure, the course of the in the hospital was uneventful. And I would like to, after this, call Dr. Soumya SR Pathology to discuss pathological aspects.
Good afternoon, everyone. So, section examined showed a highly cellular tumor comprised of small round cell tumor cells. And here in this low power, we can appreciate the arrangement of the tumor cells. The tumor cells are arranged predominantly in sheets as well as nodule formation. In this low power, we can see the morphology of the tumor cells. The tumor cells showing mild to moderate nuclear pleomorphism, having round to irregular hyperchromatic nuclei and brisk mitosis. In this reticulin stain, we can better appreciate the nodule formation as the tumor nodules are reticulin poor and the perinodular area is reticulin rich. So we performed immunohistochemistry, for which the tumor cells were beta-catenin negative, YAP1 was focally positive, and GAP1 was strongly positive. Here we can appreciate the granular cytoplasmic positivity of the GAP1. P53 was negative, and MIB labeling index was 30 to 35% approximately. So with the current approach based on immunohistochemical combination, as medulloblastoma is divided into 4 subgroups, that is vein, SSH activated, non-vein, non-SSH activated, that is group 3 and group 4. So based on, for this case, based on our IHC marker, which is GAP1 positive, GAP1 was focally positive, it belonged to SSH activated subgroup, which is P53 wild type. So as the current genomic landscape has expanded the molecular characterization of the all 4 subgroups of medulloblastoma. So here in SSH activated subgroup, the most common tumor suppression mutation, that is 42%, is SPITCH1, along with SMO, that is 12%, and SUFU, that is 10%. And they show predominantly desmoplastic morphology. However, classical and large cell anaplastic type of morphology is rare in this tumor, and infant have a good prognosis. Thank you. I would like to call Dr. Arjun, GR Pediatrics.
So I would like to thank all the residents. So just finally summarizing the case. We had a 7-month-old baby first born to a non-consanguineously married couple with antenatal detection of ventriculomegaly. Born with a large head and parents noticing progressively increasing head size, but without any features of raised ICP. Initial imaging with this suggestive of a posterior fossa mass, likely medulloblastoma, for which the child underwent neurosurgical resection, with the intra-op finding suggestive of gross total resection. Histopathological examination of the specimen done suggested the tumor to be medulloblastoma, and that too belonging to the sonic hedgehog pathway group. So we had the diagnosis, we did the definitive treatment, but one of the biggest red flags that this child had, that he had an infantile brain tumor. So a tumor presenting at a very young age is a big red flag for any underlying cancer predisposition syndrome. So now I would like to invite Dr. Kritika, our senior resident from the Division of Pediatric Oncology, to summarize the further course and the challenges and aspects of management.
Good afternoon, everyone. Taking you forward, CNS tumors, why are they important for us? They're the second most important childhood malignancy. They're the most common solid tumor in childhood, and they're the most common cause of childhood cancer death. The peak age is around 3 to 7 years of age, so our child was actually quite young to be having a brain tumor. And the incidence in India is said to be around 5 to 10 per lakh, which is slightly more than the incidence that's found in some developed countries. Our Indian data found across most of our major centers suggests that of all the brain tumors, medulloblastoma is around the second most common after the pilocytic astrocytoma. Infantile CNS tumors are basically tumors that present within the first year of life. There have been a few retrospective reviews all over the world on infantile brain tumors. 2 of them described medulloblastomas among their population at around 11% to 15% of all described infantile brain tumors. Data in India, though, is a little bit lacking as to their exact incidence. Though we do have some data on how many children do present below 3 years of age, the exact proportion below 1 year of age is usually not mentioned in most of our studies. So why is this important? If a child presents within the first year of age with a brain tumor, there are certain anatomical challenges we need to consider. For starter, the child has wide open fontanelles and open sutures. So the features of raised ICP are often masked by these. The other thing is things like frequent falls, clumsiness. These are all occurring at a time when a child is just learning how to walk. So these features are often masked by normal developmental milestones. And of course, such a small child has underdevelopment language skills. So you can't expect too many complaints from the child with regards to his symptoms. What is even more important is the treatment challenges that we encounter. So the majority of brain development, sensory, language, as well as higher cognitive functions peaks at around 3 years of age. So in children with brain tumors below this age, not only because of the pathology per se, but any modality of treatment actually predisposes them to poorer neurodevelopmental outcomes, especially radiotherapy, which is actually one of the mainstays of brain tumor treatment. It's contraindicated within the first 3 years in many tumors. And the last thing is, if you forego radiotherapy, you need to give intrathecal chemotherapy, and repeated access of intrathecal space in such a small child is often a challenge, especially to maintain strict asepsis in these babies. So what are our options when we treat medulloblastoma? So the most common option is to give chemotherapy along with focal radiotherapy. Though as discussed in our baby, because he was just a year old, this was one of our options that was less likely. So we reviewed other trials that have occurred. There are some non-methotrexate based options. These involve platinums as well as alkylating agents. Then there are some trials on methotrexate based with intraventricular methotrexate. This is the HIT-SKK series of trials. And finally, the last approach is to give high-dose chemotherapy and then perform an autologous stem cell transplant. This was covered in the Head Start series of trials. So what we did is we reviewed all our options. We discussed it within the unit as well as in some other interdivisional tumor boards. And we zeroed in on the HIT-SKK methotrexate based protocol. Every cycle for this entailed at least 2 to 4 cycles of intraventricular methotrexates, which were delivered in our baby via an Umaya shunt that was placed. So this is our treatment plan. Initially, after surgery, luckily for us, we had a gross total resection, so we didn't require a resurgery. We gave him 3 cycles of the SKK regimen, which consists of high-dose methotrexate along with other chemotherapeutic agents. And what we found at our first assessment point is that the child was in complete remission. So these are the radiological features. So these 2 images are flare images, axial flare images, and we see that in the region where we spotted our first posterior fossa mass, we do not see any recurrent or residual lesion. There is communicating hydrocephalus as evidenced by dilatation of the entire ventricular system. Diffusion weighted imaging plays an important role in the diagnosis of medulloblastoma because, as told by Dr. Soumya, it is a very cellular tumor. So, but however, in this diffusion weighted image, we do not find any obvious diffusion restriction, which is evidenced by any bright spot. And on the corresponding ADC map, that is an apparent diffusion coefficient map, we do not see any dark spot. So overall findings were all suggestive of a complete response. Following this, we gave 2 more modified cycles of chemotherapy, and our NMRI was also suggestive of complete remission. He completed his treatment in August 2022. Apart from this many months of therapy for an infantile brain tumor, another thing we reviewed was whether the child may have an underlying cancer predisposition syndrome. Before we get into that, are we justified in omitting radiotherapy, which is supposed to be a mainstay? So this is the findings of the HIT-SKK protocol that we used in our baby. And what they found is that in children with no residual tumor and no metastasis, they find a progression-free survival of around 82%. And most trials in older children who do use RT, the best outcomes reflect around 83% event-free survival. So yes, by and large, we were justified that we have not foregone any long-term survival. And coming to long-term morbidity, what they have found in this trial is children who received radiotherapy along with systemic chemotherapy, these will be your historical cohorts, versus those who received systemic and intraventricular chemotherapy as we gave in this child. Neurocognitive outcomes were actually significantly worse if you give them radiotherapy. When we reviewed children who present with medulloblastoma of the SSH variety, what they found in this large cohort is that between 14 to 20% of children actually have an underlying cancer predisposition syndrome, which led us to the next part of our workup. As Arjun mentioned before, one of the red flags for hereditary cancer would be the younger age at tumor diagnosis. So this baby presented to us at just 1 year of age with a medulloblastoma. And the suggested algorithm is that in children less than 3 years of age, we test for SUFU and patch1 mutations, which is what we did for our baby. And what we found is that he did have a heterozygous patch1 mutation, which is responsible for Gorlin syndrome. So what is Gorlin syndrome? It's actually a cancer predisposition syndrome, which is characterized by multiple anatomical defects, as well as certain tumors, including basal cell carcinomas, medulloblastomas, and odontogenic keratosis, which present. So reviews have suggested that 2.4% of children with patch1 mutation Gorlin syndrome develop medulloblastomas. Our baby happened to be one of these. These are some of the reviews previously that have looked into how many patients with medulloblastoma are likely to have this Gorlin syndrome underlying. And actually, it was quite a small proportion. It was only around 1 to 2% in a lot of these studies. But what is important to note is, especially in these older studies, they had a very short lag time before they developed basal cell carcinoma. This again emphasizes the fact that children with cancer predisposition syndromes have to be treated quite carefully, especially with regards to developing further malignancies. So these are our Indian studies. There are 48 case reports of Gorlin syndrome in India up until now. And up until 2014, none of them had described medulloblastoma at all, though 11 of them had macrocephaly, which was also there in our baby. Subsequently, when we reviewed literature, we found one case that had reported it in 2020. So at least in the Indian cohort, either there are fewer medulloblastomas or we're just not testing enough for Gorlin syndrome in our cases of medulloblastoma. What are the implications of this for us, though? One is, of course, as we discussed, radiotherapy in these patients would be precluded even if this was not a small baby. The other thing is we have to continue to screen them for associated anomalies post their therapy completion. And what about further pregnancies? We first test the patient parents to determine whether it's a familial or a de novo mutation. After that, we can offer prenatal testing in case of further pregnancies. For our baby per se, since it's an autosomal dominant and high penetrance mutation, 50% risk of inheritance to all his offspring. So our current status, our child is now 1 year, 9 months of age. He has gained milestones since his presentation to us. He is now able to sit without support. He has a mature pincer grasp. He's learned about 4 to 5 words with meaning, and he started to imitate simple actions. And we hope that he'll continue to develop at a better pace now that he's completed treatment. This is his end of therapy MRI, as you can see. So on the non-contrast T1 and post-contrast images, we see that the post-operative changes are seen. However, there is no residual or recurrent lesion. The hydrocephalus still persists. Again, overall findings suggestive of a complete response. So this is our follow-up plan. In addition to the fact that the child is a medulloblastoma survivor, we have to keep in mind that he does have an underlying cancer predisposition syndrome. These are the current recommendations for surveillance. This baby from the age of 10 years onwards will undergo an annual dermatological examination for basal cell carcinomas. From 2 years of age, he'll have a dental examination, and from 8 years of age onwards, he'll undergo an OPG for odontogenic keratocytes. Meningioma is another brain tumor that's known in these babies. So from 3 to 5 yearly after the healing of the medulloblastoma, we'll continue to screen him by MRI brain. And as far as cardiac fibromas are concerned, we did an echocardiogram at baseline, and our baby does not have any cardiac fibromas. So the challenges for this, for our unit at least, was that it was our first infantile brain tumor, and he had a cancer predisposition syndrome. Both of these precluded using of RT, which is the traditional treatment in medulloblastoma. So we had to review new methods that we could use. Repeated intraventricular drug administration was, as we mentioned, a little bit difficult, but our Omaya reservoir helped us there. We were lucky to have the support of neurosurgery, pathology, as well as radiology team. And now we plan to continue to follow him up long term, and our genetic counseling will occur subsequently. This is our baby currently in the current. Thank you very much.
Thank you, Arjun and Kritika. So before I open it to the house, we have our neurosurgery colleagues, Dr. Deepak Gupta and Dr. Shweta, who are sort of managing the neurosurgical aspect. So do you want to make some comments and your experience in these such tumors?
No, thank you very much. First of all, because we as neurosurgeons, when we operate such cases, we never get to know what happens to them. Because, in fact, there was a very beautiful study carried out in Trivandrum, wherein they found that when they started this tumor board, the compliance of the therapy and the follow-up, they increased significantly. I think from 32% to 78%. So I think it's high time our institute needs it. And this case actually shows that how beautiful a team management can manage a patient. So we are actually thankful to you. For us, our role is actually not very great, I would say, when we just take out the tumor and hand it over to the. In this case, we could not hand it over to the radiotherapist because, as we know, the RT cannot be given. In fact, interesting thing is that in our country now we have got two proton beams. I hope institute also gets it. With the proton beam, we can actually bring down the RT age to less than a year and a half. So there is one as TMCH and one at, I think, in Tata Mumbai and one in Chennai. So they are giving it to the children as young as a year and a half of age. So that age has actually come down. But this case is beautifully managed, and thank you so much.
Any other comments or anything from the pathology, Dr. Vishali? Would you want to say something on the histopathology? Or any other comments?
I would just like to add that, with 2016 classification of medulloblastomas, a lot of things have changed when we are analyzing these tumors. Of course, we call them as grade 4 tumors, but now we all know, like today itself, it was discussed that medulloblastomas, they comprise of 4 main subgroups, that is Wnt, SHH, non-Wnt, and non-SHH. But now, interestingly, in 2021, they have given 12 provisional subgroups, and all these subgroups have been identified on whole genome methylation classification, and they have associated with different genetic alterations, different age groups, and it would be really interesting, to classify them further. Maybe in this child, if we have, I look into our tumor bank, and if we have fresh frozen tissue, we will take it for whole genome methylation also, just to correlate what it comes out as. Thank you.
Thank you. Any other comments, sir? Do you want to say something? Dr. Bakar, okay. If there are no comments, I think we'll just close this session. Over to the obstetrics and gynae department. Thank you.